And now for a brief introduction about Dr. Barbara Connolly. In 2011, Dr. Connolly received the Nora Fisher Clinical Movement Disorders Fellowship Research Grant from Parkinsons Society Canada. So for all of you who have participated and had pledge sheets filled in to support Parkinsons Society during the Super Walk recently, and you say, what do you really do with our money? Very shortly, you will have a lovely young lady standing up here before you that shows you where some of our money goes to support people like her with research grants into Parkinson's. In her write-up in the research highlights, at that time she said, when people with Parkinson's have been living with their illness for years, the disease can become more difficult to manage, sometimes beyond the expertise, even of their own neurologists. That's why Dr. Connolly, who is herself a neurologist, also wanted to become a specialist in Parkinson's. She spent the next year at Toronto Western Hospital Movement Disorders Clinic as she wanted to become an expert in not just the motor symptoms, but also the non-motor symptoms, such as issues with cognition, pain, and all of the other non-motor things that people with complex forms of Parkinson's experience. She said, quote, I'll be a resource for neurologists in the community that I am a part of. Well, she did exactly that, and she is exactly that. Dr. Connolly provides her world skills and expertise to patients in the Hamilton and surrounding area. Further, being a part of the province where we have so few specialists and they are in such short supply. I have had the personal privilege of spending a day with Dr. Connolly in her clinic. I can also share that her empathy and compassion for her patients is very evident. So combined with her knowledge, this, in my opinion, makes her the perfect speaker for us today on the topic of non-motor symptoms, what they are, and how to manage them. Please make a warm welcome to Dr. Barbara Connolly.
Thanks very much for having me here, and thank you very much all for coming. It's a pleasure to be able to talk to you today, and I hope I don't overwhelm you with information. This is a topic that is quite diverse and complicated, and I've really tried to mention as many of these non-motor symptoms as I can so that if you're experiencing them, you realize that they are potential symptoms of Parkinson's disease. It's gone to, let me start it up again. Okay, so who am I? You got a brief introduction for me. I am a movement disorder specialist at Hamilton General Hospital in Hamilton. And in addition to seeing a lot of people with Parkinson's, I see my practice is about 60 to 65% Parkinson's disease. I do see a lot of other conditions as well, symptoms that are related to Parkinson's and other movement disorders such as dystonia, ataxia, tremor, myoclonus, and Cree, all sorts of different movements. In addition to my responsibilities in my outpatient clinic, I also treat general neurology inpatients at times during the year, and I have a big responsibility teaching neurology residents and residents from other faculties such as geriatrics and internal medicine, and I also teach medical students. And then I am engaged in some research. My goal, I've been in practice now for about 2 years, and that will ramp up over the years, I'm sure. So my objectives for this talk include discussing the frequency and significance of non-motor symptoms, describing the diverse array of these symptoms in Parkinson's, and discussing management techniques for these symptoms. Just a lot of time, as you guys know, the term Parkinson's often is this called PD. I use that a lot, and non-motor symptoms is NMS. And so if you see that, just so you know what it means. First, I want to introduce Dr. James Parkinson. Dr. Parkinson, you might be aware, is a person who is the eponym for Parkinson's disease. Dr. Parkinson lived from 1755 to 1824. And he was a surgeon, politician, geologist. He had a lot of different roles. But near the end of his life, around 1917, he published a very important work called The Essay of the Shaking Palsy. And this was the first description of Parkinson's disease. In this book, he emphasized tremor, bradykinesia, which is the slowness of movement that people with Parkinson's experience, stooped posture, and gait impairment. And these are all motor symptoms of Parkinson's disease. And obviously, the most obvious when you see someone with Parkinson's disease. He didn't actually mention the stiffness, the rigidity of Parkinson's, because at that time, doctors actually didn't touch their patients. And so he wouldn't have been able to appreciate that the arms and legs of people with Parkinson's are very stiff. Now, when people think about Dr. Parkinson's first essay, they don't really bring up non-motor symptoms. Actually, he did mention many non-motor symptoms in his initial report. He was cognizant of them, but they really were ignored for many, many years. And it's only the past couple decades that people have begun to understand what a significant role non-motor symptoms can play in the lives of people with Parkinson's disease. So just a basic understanding of Parkinson's that most of you will probably have a reasonable understanding of. Many of the motor symptoms seen in Parkinson's are related to dopamine deficiency. So in Parkinson's disease, a type of brain cell, a neuron, in a region called the substantia nigra, which is located at the top of the brainstem, begin to degenerate and die. These brain cells in this region are very important. They produce dopamine. And so when they die, the amount of dopamine produced in the brain starts to diminish, and this leads to a lot of the motor symptoms. I'm not sure if you ever have actually seen a pathological slide of someone with Parkinson's, but I just wanted to show it to you. It's kind of interesting. So this big cell here is a neuron, and we know it's a substantia nigra neuron because of all these little black speckles in it, or brown speckles. These brown speckles are melanin. The specific aspect of the substantia nigra is that these cells contain a pigment called melanin. And so we know we're in the substantia nigra, and we know this is a neuron that is supposed to be producing dopamine. Unfortunately, this neuron has this little body in it. This is called a Lewy body, and you've probably heard that term before. A Lewy body is the pathological kind of important feature of Parkinson's disease. So people with Parkinson's, these structures called Lewy bodies kind of come up in the cells. And these Lewy bodies are filled with a protein called alpha-synuclein. There's a lot of research going on right now on understanding the role that alpha-synuclein and Lewy bodies play in Parkinson's. But we know that these occur in these cells, and the cells end up dying, unfortunately. And we rarely do autopsies on people with Parkinson's anymore, but you'd see these Lewy bodies within the substantia nigra, as well as in actually many different areas of the brain. Unfortunately, they are not only limited to the brain cells in this region, but they spread out throughout the brain in other areas. And because of this, because they spread to other areas, it is not only dopamine-producing cells that are affected in Parkinson's, but cells that do other things as well and produce other neurochemicals, such as acetylcholine and serotonin. And because of this, people can get a lot more symptoms than just those related to dopamine deficiency. And unfortunately, because they're not related to dopamine deficiency, they generally don't respond to levodopa and the other treatments for Parkinson's disease. So in addition to the neurochemicals, other than dopamine being affected, your autonomic nervous system is affected. Your autonomic nervous system is the part of your nervous system that is responsible for innervating and controlling your organs and your sweat glands. And so these nerves become affected. The ability of your organs to function, some of your organs, so it's not like your intestines, for example, become impaired, and sweating can become impaired, which I'll speak about briefly as well. So there are major classes of non-motor symptoms in Parkinson's, are divided into sensory symptoms, mood disorders, psychosis, such as hallucinations, cognitive dysfunction and dementia, such as so thinking and memory troubles, disorders of sleep-wake regulation, so sleep issues, and this autonomic dysfunction related to that autonomic nervous system. Almost 100% of people with Parkinson's have at least one non-motor symptom. It's very, very common. Interestingly, though, 68 to 88% of older individuals without Parkinson's also have non-motor symptoms. So although it's important to be aware that they can be present in Parkinson's, we can't always jump to Parkinson's as the absolute cause of a non-motor symptom. It may be something else, and that's very important to keep in mind so that you don't miss out on treating something else. But people with Parkinson's do tend to have worse non-motor symptoms. They have a larger number of them, they're more frequent, and they're more severe. Non-motor symptoms can be the presenting features to the first symptom of Parkinson's disease in as many as 20% of individuals. They may appear years before, even decades before, someone actually is diagnosed with Parkinson's disease. Non-motor symptoms increase in prevalence over the course of illness, so they become more common over time, and they're interestingly more common in people without tremor than people with tremor. Non-motor symptoms can also show a pattern of fluctuations. You may have heard of the term fluctuations with respect to your motor symptoms. So this is kind of a diagram trying to show this, but you see this horizontal line in the middle. Above that is control of your movement, control of your slowness and stiffness and tremor, and below this line is poor control. So you're off if you're below the line and on if you're above it. And oftentimes people throughout the day, they fluctuate between having good control of their symptoms, and then as their medication wears off, their symptom control deteriorates. And it goes kind of up and down throughout the day. It's something that I work with my patients to try to stabilize. In the same way, non-motor symptoms can also fluctuate. And so it's important, if you think you have a non-motor symptom, to try to determine whether it's related to these fluctuations in your medication and your other symptoms as well. Non-motor symptoms play a huge role in the quality of life of patients, even more so than motor symptoms, and so it is really important that they be addressed and managed as best possible. They contribute significantly to overall disability, so a person's ability to do things and care for themselves and be independent. They're also related to nursing home placement, more so than movement-related symptoms. So people with a lot of non-motor symptoms are more likely to have to move into a nursing home. And for clinicians, non-motor symptoms can become a major therapeutic challenge in advanced stages of Parkinson's. And so it's really important that patients and clinicians are aware of all these features and have a good sense of how to manage them. Unfortunately, I find that a lot of time non-motor symptoms are not addressed. A general neurologist, I find a very good job of managing motor symptoms. A lot of the time, they often forget or just don't have time to get into non-motor symptoms. And because of this, it can lead to a lack of a prompt diagnosis, which causes people to remain untreated for prolonged periods of time. And so, it's certainly partly the responsibility of the clinician to ask, but it's also the responsibility of patients who are now educated in non-motor symptoms to bring up their concerns in this regard. They're having a number of different questionnaires developed to assist with the identification of non-motor symptoms, and these are used in some clinics, but certainly for research purposes as well. And this is one of them. It's called the Parkinson's NMS questionnaire, and really it goes through all sorts of non-motor symptoms in a yes or no fashion, and it can provide a brief understanding of what someone is dealing with. Sometimes people bring something like this to their appointment with me, and they kind of show it to me at the beginning and say, this is how I'm doing. And so I have a good sense right from the start for what their major issues are. I should mention, because there are so many non-motor symptoms, it is really challenging to address them all at a single visit. The standard of care within medicine is to try to address things at least on a yearly basis. And so when I see my patients every 3 to 6 months, I generally have a kind of a pattern of asking certain ones at certain times, so that over the year I ask them all, but it's so hard to get into every single one at every visit. Not only are patients affected by non-motor symptoms, but caregivers. Caregivers can develop depression and anxiety trying to help their loved one deal with non-motor symptoms. They can have sleep disturbance because of bladder troubles in the person with Parkinson's that keeps them up as well, or other sleep issues. They can feel isolated because they have to stop going to social events because their partner or loved one has kind of withdrawn a bit because of their Parkinson's. And there's a loss of freedom because they often are now unable to go out on their own because they have to stay with the person with Parkinson's because they can't be left alone, for example. So it's important for not only the patient but for their family and friends to manage these symptoms. Now, with respect to medications, there are a lot of different medications for non-motor symptoms. And when I discuss these issues with my patients, I always emphasize that you don't have to treat them with medication unless they're really bothersome. Having Parkinson's, people are often on a number of different medications, and then they have their other medical conditions for which they're on medication for. So it ends up being a lot of medication. Some people just don't want to be on anything else, and that's okay. And so it's up to the patient to decide if it's bothersome enough to warrant treatment. And so I really try to give people the option and tell them what's available, but it's certainly, you don't have to absolutely treat a non-motor symptom unless it's impacting your life. So first off, sensory symptoms. So the first one, and one I always ask about with people, is smell issues. So anosmia is the medical term, loss of sense of smell. Loss of sense of smell can happen very early. It can happen even decades before a person is diagnosed with Parkinson's disease. And actually, they found that Lewy bodies are present in the part of the brain that is involved with smell. It affects up to 90% of people with Parkinson's, but 70% may be unaware that they even have a loss or change to their sense of smell. With loss of smell, loss of taste also occurs. And with this, often loss of appetite and then weight loss. I find this is extremely variable. I've had patients who they've lost their sense of smell and they no longer want to eat. They used to take such a pleasure out of eating, they've lost that, and they end up losing weight. So this is a really important symptom because it can lead to weight loss and the issues that come with that. There are some interesting tests that can be done. So we know the smell because there's a lot of research equipment that can be used to check different smells. And these are just a couple ones. One's called the smell identification test and one's called sniff and sticks. And so lots of studies use smell as a way to help diagnose Parkinson's. And there are things you can do to help yourself if you are experiencing this and have a diminished pleasure and taste. Certainly choose foods with enjoyable textures, with strong flavors, and rich in nutrients. If you're going to put it in your body, even if you don't feel like it, at least make it something that is healthy for you. When you experience weight loss, one of the most important things is to make sure that something else isn't going on. There are a lot of causes of weight loss, and unfortunately, cancer can cause weight loss. And so don't just attribute it to the Parkinson's and mention it to your family physician. Another way is, of course, to use nutritious shake. There are different brands available, or if you're creative, you can make shakes at home. But this is a good way to get calories into your body. I just wanted to mention this special diet allowance because I find a lot of people aren't aware of it. There is a special diet allowance available through the government to help people on social assistance with the extra costs of buying the boosts or the onshore drinks on a regular basis. I have patients who take 3 a day, for example, and it's extremely expensive to do that. There is this, so Parkinson's is one of the conditions that the government will help to fund these nutritious shakes and other supplements. So you actually have to go, unfortunately, to the Ontario Works or ODSP office to obtain the form. You then bring it to your physician, they complete their part, and then you complete your part, and you have to bring that original form back to the office. So there is a way to, you certainly look into this if this is something that you're dealing with. So I also want to mention pain and other sensory symptoms of the body. So some people experience tingling or numbness in their toes in particular. It can be all over the body. And some people experience pain. These symptoms can be related to a lot of different things. Sometimes they're related to the motor symptoms. So if you have a lot of stiffness in your limbs, that can cause pain. Dystonia is when a body part wants to posture or excessively stiffen. I have this little picture here of these toes, and you can appreciate the toe sticking up here. And a lot of people have this, who I see, and this is a symptom of Parkinson's disease, dystonic toe. And other things that can happen, nerves can be involved with Parkinson's. There's some research that suggests that being on levodopa even long term can damage the nerves a bit. So this is not absolutely 100% determined, but there is research looking into if long-term use of levodopa affects the nerves in itself. Central involvement means just related to the brain. When the brain is affected with Parkinson's on all those Lewy bodies, you can actually have damage or irritability to the pain centers in the brain, and that can cause body pain. And then akathisia. Akathisia is a term that means an inner restlessness. Not everyone with Parkinson's has this. It's usually a small group, but it's a really uncomfortable feeling that just makes them want to move all the time. And this is a very uncomfortable sensory symptom. All these sensory symptoms affect social and physical function. People often withdraw from their social groups, and they stop being active because of them. And again, it's important to check for other causes such as orthopedic issues, arthritis, things like that. To manage pain, there's of course lots of different pain medications, from very mild things like Tylenol and Advil up to, in some cases, narcotics. Muscle relaxants can be helpful if there is a lot of stiffness. Botulinum toxin injections or Botox injections. People know Botox because of its effect on wrinkles, but Botox, what it does is it relaxes muscle, and so that big toe you saw sticking up, it can inject the muscle that's causing that big toe to stick up and relax it. So that can be very, very helpful, and then physical therapy can be helpful for pain as well. There are also visual symptoms of Parkinson's disease that are I think, out of a lot of them, this is one of the least recognized symptoms, non-motor symptoms of Parkinson's. People with Parkinson's can develop impaired color discrimination, so they can't differentiate the green and the red of this picture to see the number 8. Sometimes they can have contrast sensitivity. So this diagram here at the bottom with all these little gray circles, you can see in the upper left that you can tell the difference between the black and the white areas. And as you go towards the bottom right, it becomes less distinct. People with Parkinson's, they have a greater difficulty determining where the black and the white lines are. Something called convergence insufficiency. Sometimes people with Parkinson's have difficulty with near vision. Their eyes, when you look near, your eyes turn in, and that can be quite difficult for Parkinson's. And prism glasses may help that. People with Parkinson's can develop dry eyes, and they can develop something called seborrheic blepharitis, where they get itchy and scaling and redness to their eyelid. That tends to respond to warm compresses and regular wash. Unfortunately, there's really no treatment available for the color discrimination and the contrast sensitivity issues. Because I was speaking about seborrheic blepharitis, I thought I should mention seborrheic dermatitis. People with Parkinson's can develop this condition. It's a mild inflammatory skin disorder where they get scaly, itchy, flaky red skin, usually at sites that are prone to sweating. Topical corticosteroids or antifungals can be effective, and then some people use antihistamines to reduce the itching. Some people do see a dermatologist to help with this if it's quite severe. With respect to mood and psychiatric disorders, first thing to talk about importantly is our mood disorders. There are 3: depression, anxiety, and apathy. These are the top 3. And these occur quite frequently and have a huge impact on quality of life. They can occur very early and before people are diagnosed with Parkinson's, or occur later on. They generally lead to people having worsened motor symptoms and more disability. So these are extremely important to treat. Depression happens in about 52% of individuals with PD, and oftentimes they don't come to me saying that they're depressed. They may say that they just don't like doing things that they used to like to do anymore. They have sleep issues, they feel sad, they feel that they cry more easily. So there's a lot of different symptoms that people can experience with depression. With respect to depression, there are a lot of non-pharmacological methods to try to manage it. Talking to some sort of professional, whether it be a counselor, a social worker, a psychologist, psychiatrist, can be very helpful, although I must say it's very challenging to get people in with a psychiatrist. They're few and far between, unfortunately. Exercise can be helpful. I often recommend to my patients that they consider mindfulness meditation. There's great evidence that mindfulness meditation helps with depression in general. And there's a few small studies that show it may help when Parkinson's-related depression, but it's certainly worth a try if you're not interested in using medication. And then something called transcranial magnetic stimulation is a new, very complicated technique where they use a sort of wand above part of the brain to stimulate the brain, and it has been shown to help with depression. It's only done in very specialized centers because it requires a lot of training to be able to do. And the long-term effect of this treatment is not great, unfortunately. Of course, there's also medications. People with Parkinson's can use the same medications as people without Parkinson's disease. I find that oftentimes family doctors are a bit nervous about starting antidepressants in people with PD, thinking that it might affect their motor symptom control. There's a lot of studies that show that the same medications for non-PD depression can be used in PD depression. And I should mention pramipexole. There was a study that showed that pramipexole, one of the dopamine agonists used for Parkinson's, can help with depression. Even in people who don't need it for motor symptoms, it can actually help depression. So that's quite interesting. Anxiety. In Parkinson's, people with anxiety may experience panic attacks, just phobias to going out in public, and more generalized anxiety. Prevalence is about 25 to 50% of people. And it's an important point that this may be a wearing off symptom. So sometimes when people are wearing off from their medication, that's when they start to experience the anxiety. And so that's an important thing to be aware of, because certainly you can, by changing your schedule or adding something like Compdan, you may be able to smooth this out and avoid the anxiety. Similar non-pharmacological and pharmacological approaches to anxiety as depression. We unfortunately don't have any other new medications for anxiety, other than that fact that we sometimes use sedatives like benzodiazepines, such as clonazepam, to help in occasional cases. Apathy. Apathy is really defined as indifference, just not interested, don't care about anything anymore. And sometimes this is very difficult to separate from depression or fatigue, but it occurs in about 40% of people with Parkinson's. It's actually more frustrating for caregivers than the people experiencing it, because people experiencing it just don't care, whereas the caregivers are very frustrated that they can't engage their loved one in exercise or social activities, things like that. Hallucinations are also a very important non-motor symptom that occur in a good proportion of people. Hallucinations are, I say to my patients, hearing or seeing things. The most common thing is visual hallucinations. Almost all the time it's visual more so than auditory. The visual hallucinations can be seeing loved ones in the house, seeing people on the front lawn, seeing dogs or cats around, bugs on the wall, things like that. The hallucinations can be caused by Parkinson's itself. It's not always the medication. Just having Parkinson's makes people with this disease prone to getting hallucinations as the disease progresses. But Parkinson's medication can exacerbate hallucinations. And also other medications, non-Parkinson's medications, and infections or other illnesses. So if someone has a kind of sudden onset of hallucinations on my patients, I don't just think it's the Parkinson's. I make sure it's not a urinary tract infection, which is just so common and can cause hallucinations in older individuals quite easily. So it's very, very important to look for other causes and not just blame Parkinson's and the medication. Hallucinations are actually the strongest predictor for nursing home placement for people with Parkinson's. So this shouldn't be overlooked. But I must say they don't always need to be treated like a lot of the symptoms. And if they're not distressing, I have some patients who they may see their mother, and they actually enjoy seeing their mother. She's being long gone, and they're happy to have that moment. And so if it's not a distressing or upsetting thing, sometimes we don't treat, but other times it can be extremely distressing. There are some non-pharmacological methods to try to manage hallucinations. It's important that during nighttime that a person is able to orient themselves. Nighttime is the most common time that people develop hallucinations. So you having a night light on or keeping the bathroom light on can be helpful. And certainly turning on the lights when you're rising from bed at night can be useful, because people are often a little bit, a little groggy, confused at night. And if it's dark and you're seeing shadows, it's easy to make that into a hallucination. Open the windows, let the light in during the day. Don't have a dark room during the day. It's good for the brain to understand it's daytime, and it's orienting, and can help with hallucinations. And then oftentimes people develop hallucinations when they're in an unfamiliar place. So if people have a lot of hallucinations, I caution against going on a big trip somewhere that they've never been to before, because these types of environments can bring on hallucinations. I also, when people have hallucinations, I try to remove some of their Parkinson's medications. So there are medications like amantadine, some of the dopamine agonists, pramipexole, ropinirole, rotigotine patch, and selegiline or rasagiline can all contribute to hallucinations. Now, levodopa can too, but levodopa is our best medication for treating the motor symptoms. So I often try to get rid of all the extras and have people only on levodopa to try to minimize the hallucinations. It's very important that you know that some medications can worsen Parkinson's if they're used for hallucinations. If you go to the emergency department with hallucinations, the most common medication they'll try for you is risperidone. Risperidone and these other two, olanzapine and haloperidol, can have a possibility of worsening Parkinson's motor symptoms, and they really are contraindicated. They should not be used in Parkinson's disease. Rather, quetiapine is the top medication. Quetiapine works for a lot of people and can cause a bit of sleepiness during the day, so we often give it at night. But if you have hallucinations and someone wants to put you on risperidone, ask for quetiapine instead. It's the only one that you can be prescribed by a physician, most physicians, that can help hallucinations. I mentioned clozapine here as well. Clozapine is a more challenging medication to use. Clozapine can reduce your blood cell counts, and so if you go on clozapine, you actually have to get your blood drawn on a weekly basis for 6 months, then every 2 weeks for another 6 months, and every month thereafter, to make sure that your blood count levels don't go down. It's a really challenging and onerous medication to use. So it's rarely used, but is effective also for hallucinations. Cognitive impairments, these are thinking and memory problems. Now, sometimes people say, "Gosh, I find it takes me longer to think of a word. I occasionally misplace items." There is normal aging, and with aging, it does take longer to recall information. You grasp for words and names more frequently. That's normal. It becomes abnormal when it's more severe, so you're having more prominent memory issues. or other thinking, so judgment, planning, that sort of thing. And it becomes dementia when it actually impacts your functioning so that you have issues doing your day-to-day tasks because of your cognitive problems. So there's normal aging, there's this mild cognitive impairment, MCI, where it's not impacting your daily functioning, and then dementia when it is. People with mild cognitive impairment have some difficulty with thinking and memory, but it does not impact their day-to-day lives. About at least 80% of people with Parkinson's develop mild cognitive impairment at some point. And so it's extremely common to have some sort of memory and thinking issues. These issues can be present when people are diagnosed that early, but they generally occur over time and are more of a feature of later Parkinson's than early. Some people with MCI develop dementia over time. This is called Parkinson's Disease dementia. There is actually no treatment available for just simple MCI. This is a condition that a lot of people without Parkinson's have as well. There are no medications right now that we are able to give people to help with this mild memory and thinking problems. Dementia and Parkinson's disease, when it's related to the Parkinson's, it's called Parkinson's disease dementia. But just because a person has Parkinson's doesn't make them ineligible for other dementias, unfortunately. So some people with Parkinson's also develop Alzheimer's disease. Vascular dementia is another type of dementia, which is related to strokes in the brain. And then some people have mixed, where they have multiple types. I often get asked, when people develop major thinking and memory problems, I get asked, do they have dementia with Lewy bodies? Dementia with Lewy bodies I kind of liken to the opposite side of the coin from Parkinson's. In dementia with Lewy bodies, you have the dementia first, and then more than a year later, the motor symptoms of Parkinson's. Whereas if the motor symptoms clearly happen first and the dementia later, it's Parkinson's disease dementia. It's kind of potatoes, because there's really no difference in the way we treat the two conditions, but just to try to clarify that a little bit. So Parkinson's disease dementia, I often test this by doing some cognitive tests in the clinic, and some of the major features are inattentiveness, impaired judgment and decision-making ability, and poor visual spatial skills. So I ask people to draw a clock, and I tell them to put the numbers or the hands at a certain time, and they can have difficulty with that, even making the clock and organizing the numbers, and then how to put the hands. And I often ask them to draw a cube as well, and those are checking for visual spatial skills and planning skills. The memory issues of Parkinson's disease dementia are often much milder than in Alzheimer's. For Alzheimer's, it's one of the major features, memory, whereas oftentimes people's memory isn't that bad in Parkinson's disease dementia, but it's these other aspects of thinking that become affected. Unfortunately, dementia is progressive, and this can lead to a lot of issues. One of the most important things about managing cognitive impairment is to remove any possible contributing factors. Depression and other psychiatric illnesses can look like dementia, so it's important to treat that. Treat any physical diseases that may be contributing, and treat pain, because pain can also affect people's thinking. Eliminate any medications that may contribute to confusion. So these are sometimes non-Parkinson's medications. A lot of bladder medications may contribute to confusion. Sleep aids, sedatives can contribute to confusion, so we often try to remove those. And then Parkinson's, with respect to Parkinson's, dopamine agonists actually can worsen thinking in some people, and so oftentimes as people get into their later 70s and 80s, I remove dopamine agonists from use because they can contribute to that. There are a lot of non-pharmacological methods to managing cognitive impairment, and this is I did not make this up. I heard this at a talk I went to from a geriatric neurologist, basically a cognitive neurologist, and I thought it was just such a great way to think about it. So consider your brain cells like trees, okay? Each brain cell is like a tree, and your brain is like a forest. And when you're younger, you have a very full, dense forest. Lots and lots of trees, and the trees' branches reach out and they touch each other, and that touching of the branches of the trees is the communication between the trees, or the communication between the brain cells. And it's that communication that allows our brain to function normally. Over time, we lose trees in our forests. It's natural to lose trees. We all lose trees. People with dementia lose more trees, and trees at a higher rate, okay? So your forest becomes more sparse over time. But even if your forest is sparse, you can still work on the connections between the remaining trees. And if you have great connections, even though you have less trees, you often still function quite well cognitively. And so although we cannot control how many trees you lose over the course of your life, and if you have dementia, you can control the connections between the trees. So to strengthen and optimize brain cell connections, one of the things I often encourage my patients to do is to learn new activities. This is painful. It's hard work to learn a new activity, but learning another language, playing an instrument, joining a local theater company, learning to dance, reading a different type of book from the type that you usually read, playing a new card game are all ways. People often say, oh, I play bridge every Friday night. I stimulate my brain that way. Your brain is used to playing bridge. That doesn't help anymore. Even if it's a challenging game like bridge, your brain is used to it. You need to do different things. It's different things that really helps the brain foster connections and build new connections. Another important thing is to maintain good brain health. Strokes, even if it's not vascular dementia, strokes really affect your brain function. And so avoiding having strokes is one of the best things you can do to avoid cognitive impairment as you age. And so treating high blood pressure, high cholesterol, abnormal heart rhythms like atrial fibrillation or diabetes are very, very important. Avoiding smoking is important. I mentioned here low alcohol intake. Alcohol at high levels is damaging to brain tissue. People often ask me if they should drink at all if they have Parkinson's. I'm a big proponent of quality of life, and so if you like a drink, with your dinner, there's no problem with that. But I'm talking about excessive drinking. Ladies, 9 drinks a week is kind of our maximum for our brain and our liver to be able to tolerate it, and for gentlemen, it's 14 drinks a week. So certainly stay under that is important. And then physical exercise. Physical exercise also enhances brain connection. There are some medications for dementia, not for the mild cognitive impairment, but for dementia, and these enhance acetylcholine levels. So dementia is not related to dopamine, it's generally related to low acetylcholine levels, another neurotransmitter. The 2 main ones that have been studied are rivastigmine and donepezil. There's another one, but there's no great studies in Parkinson's disease. These medications are usually well tolerated, but they can cause stomach upset and reduce appetite. They can slow the heart a bit, and in some cases they can worsen Parkinson's tremor, and that's one of the major things we have to stop the medication for if that happens. Unfortunately, these are not great medications, whether it be for Parkinson's disease dementia or for Alzheimer's dementia. The same medications, they don't work great. Some people notice that they feel a little more sharp or clearer thinking when they're on these medications. Sometimes they don't progress as quickly. They seem to stabilize their memory issues over time. But I wish I could say that they were really effective, but unfortunately they're not. With respect to sleep, impaired or disturbed sleep is very, very common in Parkinson's. The prevalence is close to 90%. And the most common form of sleep issue is sleep fragmentation. And this is where you kind of wake up multiple times over the night. You don't get a full night's sleep, complete night's sleep. One of the major causes of this is impaired turnability, or your ability to turn in bed. People with Parkinson's often have gone quite a while without medication at bedtime, and so they get stiff and slow at night, and that affects their ability to get comfortable in bed and can impact their sleep. Getting up to use the bathroom multiple times a night certainly affects sleep. Sometimes medications can cause insomnia, including Parkinson's and other medications, and then some people have periodic limb movements where their legs are moving around, and that affects their sleep. And the treatment depends on what issue we're dealing with. An interesting condition is called REM, sleep behavior disorder, called just RBD. This is when you act out your dreams. It's when you kick and punch and yell at night when you're sleeping. So this is the name of it. This happens in a lot of people with Parkinson's, and it actually can happen years and years and years before. There's good evidence that if you have this problem, acting out of dreams, earlier in life, even in your 30s and 40s, you have a very high risk of going on to develop Parkinson's disease later in life. I think the last study showed about 90% of people with REM sleep behavior disorder in younger years develop Parkinson's. So it is a harbinger of Parkinson's disease often. Sometimes it's not a big deal. So the reason people have this is because there's a part of the brain that paralyzes us when we sleep. And in Parkinson's, this part of the brain is affected, and so you're not paralyzed anymore. So when you're in the middle of a dream, you move around. So the people who are experiencing it, they actually are getting a great sleep. They're sleeping at the time. They're in the middle of a dream. And sometimes they're not affected at all, but it can really affect the bed partner because it can cause injuries. I've had patients whose wives or husbands have gotten black eyes because of them reaching out and punching. Sometimes it does wake you up, and it can cause a very disruptive sleep and sleep fragmentation. And then for the person experiencing it, they can fall out of bed and injure themselves that way. So if these issues are happening, I would treat it. Sometimes we don't, though. Sometimes if it's not an issue, if someone sleeps alone and there's no one else in the house and they're not falling out of bed, we just leave it alone. If treatment is required, the first thing I try is melatonin. Melatonin is something like a supplement you can buy at a natural food store or at a pharmacy. And our brain produces melatonin itself, but sometimes a little extra melatonin will help calm this down. 3 to 15 milligrams can be used. Sometimes you'll find the 3 milligram tablets. Sometimes you'll find 10 milligram tablets, depending on the brand. But anywhere from 3 to 15. So don't give up at 3 or 6. Go up if you're having this problem. The other medication for this is called clonazepam. I rarely do this. If someone has major issues with RBD, I may, but it can cause daytime fatigue and confusion. So I really do try to stay away from clonazepam. So these two conditions, excessive daytime sleepiness and fatigue, sometimes get intermixed and can sometimes be very difficult to differentiate or really understand if someone's experiencing one or the other. Excessive daytime sleepiness is an urge to sleep during the day. Whereas fatigue, people with fatigue may not actually be sleepy, they just feel exhausted all the time. So both of these conditions are very common and can be present at any stage of Parkinson's. They are associated with other non-motor features like apathy, depression, other sleep disorders, and cognitive impairment. Excessive daytime sleepiness affects about 50% of people and can be a side effect of medication. Both levodopa and dopamine agonists can cause sleepiness, unfortunately. And dopamine agonists actually can cause sleep attacks. So people, very, very rarely, but they can find that they all suddenly fall asleep without any warning. And so if you're a person that is just starting one of those medications and feeling a bit sleepy, it's important not to try because it's important to give yourself a little while and to see if you develop these sleep attacks. I've only seen them a few times, but they do exist. And good sleep hygiene is very important for excessive daytime sleepiness. Sometimes it's related to things that are treatable. So for example, when I counsel about good sleep hygiene, I tell people to avoid excessively long daytime naps. If you're sleeping a lot during the day, it's really hard to get a good night's sleep. At night, avoid caffeine after dinner. No exercise in the evenings, it's kind of stimulating. Avoid watching TV in your bedroom because it's stimulating. If you cannot fall asleep after 20 minutes, get up. Don't just stay in bed and suffer. Get up, leave your bedroom, go into another room and do something different. You can watch TV, read a book, do something that will make you a little sleepy. And when you feel sleepy again, try again and give yourself again another 20 minutes. So don't just stay in your bed all night. It kind of ends up giving you negative feelings about bed and anxiety about going to bed. So it's important to get out of bed and use bed for sleeping only. And arise at the same time each day. So don't just sleep in because you had a bad day. Get up, and this will train your body to get a good night's sleep at night when it has that opportunity. Fatigue is present in about 1/3 of people, and it's often described as the most disabling symptom. It tends to be worse in older people and people with longer duration of disease, and it's associated with worsened motor symptoms, worsened social and psychological behaviors. People often withdraw because of fatigue. Higher severity of depressive symptoms, and other sleep disorders as well. Managing both these problems can be challenging. There are a few medications here, modafinil methylphenidate, which is Ritalin, also used for attention hyperactivity disorder. Rasadrolene and selegiline may help, amantadine. And there's some thought that fatigue may be a symptom of an off symptom, and so adding levodopa may be helpful for that. There are other measures that you can do to help. Regular short naps. Naps aren't bad. Some people just have always been against naps, but a 20 to 40 minute nap is rejuvenating. It's not it's not long enough to affect your nighttime sleep typically, but a morning nap and an afternoon nap, both short, can be helpful. Exercise is also very helpful, and then those sleep hygiene suggestions that I gave you already. Autonomic dysfunction now. So orthostatic hypotension is defined as a major reduction in blood pressure when you stand up. This can be from going from lying to sitting to lying to standing, from sitting to standing, but with a change in position like that, blood pressure can drop in people with Parkinson's. The top number dropping by at least 20 points, or the bottom number of blood pressure by at least 10 points is considered a diagnosis of orthostatic hypotension. So I just gave you an example here. This occurs in almost 60% of people with Parkinson's, but only a minority actually have symptoms from it. But it's really important to be aware of if you have symptoms. Symptoms include dizziness, lightheadedness, blurry vision, confusion or foggy thinking, nausea, weakness, or fainting. It can all occur. The most worrisome one is, of course, fainting, because people who have this can injure themselves. This can lead to people having bleeds in their brain or hip fractures. So we take this very seriously if people are having symptomatic orthostatic hypotension. There are a lot of non-pharmacological measures for managing this problem. I tell people, avoid getting up quickly. When you're waking up in the morning, don't just jump out of bed to go to the bathroom and pee. Give yourself a couple of minutes sitting up on the side of the bed before you get up. Increase your fluid intake, 6 to 8 cups a day. Most of us don't get anywhere near that. That's really important to increase your blood volume. And caffeinated and alcoholic beverage don't count in this. They make you lose water. So if you're having a lot of caffeine, that's not included in that 6 to 8 cups per day. Add salt to your food. This may be just sprinkling salt on your lunch and dinner. I do have some patients who drink bouillon. Bouillon has tons of salt, so it can be vegetable, beef, chicken. It doesn't matter, but 3 cups a day can add a lot of salt to your diet. Sorry, I'm just getting over a cold and I'm talking more than I usually do. Compression stockings can help the blood not accumulate in your feet when you stand up. And once in a while I tell people to raise the head of the bed by 4 to 6 inches. So this isn't, it looks good on your screen actually, this isn't just raising the head. This is actually raising the entire bed at the head. Oh, thank you. I'll keep them near me. So you have to actually put the head, the legs at the head of the bed on cinder blocks or something like that to raise them up. And that actually causes your body to, your kidneys to affect their accumulation or their absorption of water if you do that. There are also a lot of medications. And if the non-pharmacological methods don't work, we do go to medications. Sometimes levodopa can worsen orthostatic hypotension. So in people who develop it after they start levodopa, I often try them on domperidone. Domperidone can help with this. Fludrocortisone, midodrine, yohimbine, pyridostigmine, domethacin, these are all medications that can be used. I do have patients where we have to use multiple medications to get control of this problem. There are potential side effects, unfortunately. Some of these medications can actually cause you, particularly midodrine, can make you have too high a blood pressure if you lie down. So sometimes when you're on one of these medications, your doctor will caution you not to take a nap because lying down can actually bring up your blood pressure too much. But I really want to emphasize that this problem is not a choice between too high or too low blood pressure. I'm not telling my patients, get your blood pressure up to 180 over 110 or something like that. People are often, they've been told all their lives that salt is bad, that high blood pressure can lead to strokes and heart attacks. And certainly, we don't want to increase your blood pressure enough that you are at risk for these conditions. But it's really important to treat it as well because falls can be just as disabling if something happens. And like I was mentioning, bleeds in the brain and hip fractures do occur because of these fainting spells. And that can change your life forever. With respect to the bladder, there are a lot of symptoms people can have. Urinary frequency, urinary urgency, so going frequently, when you feel the urge to go, you got to get there really quickly. Incontinence, then frequent nighttime voiding. In Parkinson's, because the nerves to the bladder are affected, the bladder is more irritable. So even when there's only just a little bit of urine in the bladder may want to contract and signal that you have to go. So this can be a major quality of life issue. And because of this, some people don't want to take those 6 to 8 cups of water a day because they know it's just going to contribute to their bladder issues. It's occurring in about 25 to 50% of people with Parkinson's, but it is important to consider other causes, like for everything else. Some medications can cause you to void or pee more often. Urinary tract infections are a major cause. Some often get an enlarged prostate gland as they age, and this can contribute to urinary issues. And then ladies who've had children, oftentimes the bladder becomes more loose in the pelvic region, and so any sort of movement makes it wiggle, and that signals the urge to go. So these are all other causes that can be addressed. There are some, again, non-pharmacological ways of managing. Time voiding, so don't wait until you feel that urge. Set your schedule that every 2 hours you just go to the bathroom and you give yourself a try, and that sometimes makes a big difference. Avoid fluids after dinner to avoid that nighttime trouble with going frequently at night. But it's important that if you do that, keep a glass of water at your bedside for the morning, and before you get out of bed, drink a glass of water then, because you're going to be quite dehydrated by that time, and you'll be at more risk for that orthostatic hypotension. Protective undergarments are often used. Some people have a bedside commode, so they don't have to trek all the way to the bathroom, and that's quite disruptive to your sleep if you have to go. They keep a commode at the bedside to sit and go on. And men, I always tell my patients, are lucky if they're men in a way, because they have some other options too. They can use a urinal at the bedside, and then there's something called a condom catheter, and this is like a condom, and it's placed around the penis, but it's connected to a tube, and the tube's connected to a bag. And so if you're having a lot of urgency and incontinence, and this is keeping you up at night, or keeping you from going out of the house because you know you're going to have to find a bathroom, this can provide you with a lot of freedom, because when you feel the urge to go, you just go, and it ends up in the bag. There are some medications for overactive bladder. I've mentioned here. The first three are quite, oh my goodness, I did it again, quite well known for worsening confusion and hallucinations. And so these ones really have to go if confusion is an issue. The fourth one, Myrbetriq or mirabegron, is quite new, and it doesn't seem to have that sort of issue with confusion as the others, and it's one I've been using more lately. Some urologists can actually inject the bladder with botulinum toxin and Botox and calm the bladder down that way, but that's rarely done, unfortunately. And like I was mentioning, use these with caution if there's a confusion or hallucinations. Constipation, I would say almost all of my patients deal with this. This can be present throughout the entire course of Parkinson's, and it may be prodromal, which means it may be not actually a symptom of Parkinson's early on, but just tell you that you're going to develop it. People who have a lot of constipation earlier in life often go on to develop Parkinson's disease. It can be worsened by Parkinson's medication. Levodopa and dopamine agonists can worsen constipation, unfortunately. There is some modest evidence that duodopa, the continuous infusion of levodopa through your gut, that the pump that you wear with the levodopa continuously given to you through the tube, that duodopa may actually improve constipation in some people, they found. So, but Parkinson's medication can make it worse in general. I thought this was a very interesting figure. It's from an article from 2011, and it shows your risk of Parkinson's depending on how frequent you have a bowel movement. So, so when you have a bowel movement more than once a day, okay, 2 or more times a day, you have actually a reduced likelihood of getting Parkinson's. The number 1 means there's no difference, no risk or anything, but a decimal place, 0.75, means that you actually have a reduced risk of Parkinson's if you go more than once a day. If you go daily, it doesn't mean anything. It doesn't affect your risk of Parkinson's at all. If you go every 2 days, your risk of Parkinson's is about 2.5 times that of others. And if you go less than you go 3 days or less, it's almost 4 times the chance of developing Parkinson's. So it's really, really, really related to Parkinson's disease. There's actually been some studies that have shown that Lewy bodies, those little pathological feature I showed you, are actually present in the gut, in the nerves of the gut. So we know that some of the same issues that are happening in the brain affect and damage the nerves in the gut. There are a lot of consequences of constipation in Parkinson's. Again, it affects quality of life. It can affect appetite and lead to weight loss. And severe constipation can lead to what's called megacolon, where your large intestine expands and is no longer able to contract and move feces properly. You can have obstructions or blockages of your colon. You can have twisting the intestines. It's called volvulus. This is very painful and often requires surgery. And there's something called bowel perforation, where you can actually burst your bowels because you're so full of stool. And this is a real emergency and requires surgery immediately. Management of constipation. So first thing I always encourage people is exercise. I liken constipation to Heinz ketchup. If you think about a Heinz ketchup bottle, it's really hard to get that ketchup out of it, and you have to shake it around and hit the bottom of it, and finally it'll kind of come out. But shaking and moving does get the bowels and the stool moving, and so exercise is really valuable for managing constipation. Of course, adequate fiber, increased water intake, prunes and prune juice. And then there are these pelvic floor retraining techniques, but it is challenging to find someone who knows how to do those and can teach them, unfortunately. There are a lot of over-the-counter medications for Parkinson's-related constipation and other constipation. There are these four main classes: bulk-forming laxatives, stool softeners, osmotics, and stimulants. And I'm sure some of these look familiar, these names. Lactulose is an osmotic, docosahexaene sodium or cholase is a stool softener, Senecot is a stimulant, and oftentimes you have to use multiple classes of agents to get control over constipation. One often isn't enough. You may use Senecot with cholase, or polyethylene glycol is Restoralax, which is a very good one that has been shown through research to help with Parkinson's-related constipation. There is one prescription medication currently available in Canada called prucalopride or Resotran that can be helpful for constipation. Unfortunately, it's not yet covered by the Ontario Drug Benefit Program, and it's quite expensive, so it's rare that people can afford it and use it. There's another one called lubiprostone that has been shown also through research studies to help with Parkinson's-related constipation. In December 2014, Health Canada gave it a kind of a tentative approval, but it is not yet available in Canada, but I expect within the next year or two, this medication should also be available. Sexual dysfunction. This is something that is often ignored in Parkinson's disease. For women, they may experience low sexual desire, difficulty with arousal, difficulty with orgasm, and men have erectile dysfunction frequently, difficulty reaching orgasm, and sometimes premature ejaculation. Most of the attention has been placed on erectile dysfunction. This is a late non-motor symptom. It generally doesn't happen for many years, certainly 7 to 10 years at least of Parkinson's disease. Oftentimes patients don't bring it up because they're embarrassed or feel uncomfortable talking about it, and physicians often don't bring it up either, so it's often just not mentioned. But sometimes family doctors can help manage this with medications, and then oftentimes a referral to a urologist can be quite helpful. Like other symptoms, you have to look for all the other causes: diabetes, cardiovascular disease, having prostate surgery, some other medications, and smoking can all contribute to erectile dysfunction and should be addressed without just blaming the Parkinson's disease for this problem. There are a lot of different management techniques, and those that are used for erectile dysfunction not related to Parkinson's disease often help in Parkinson's disease too. And so lifestyle changes such as quitting smoking, losing weight, increased exercise can all be helpful. Phosphodiesterase type 5 inhibitors are those famous medications like Viagra, Cialis, Levitra, which can all be helpful in Parkinson's. Injections, you can actually get injections right into the penis that can stimulate erections. There are a lot of devices that are available that can be used if people are very determined. And there are some alternative therapies. Some people find that things like acupuncture may make a small difference, although there's not good research behind them. And behavior therapy. So this is something like sex therapy. Sometimes that can be really helpful if there's even a component of anxiety or mood that's contributing to erectile dysfunction. For female sexual dysfunction, it's being unfortunately largely ignored. I believe there is a medication that's just about to come onto the market for female sexual dysfunction, but as of now, there are no good treatments for it. It's important to optimize management of motor symptoms and other non-motor symptoms because these can also play into someone's interest in sex. And it's important to rule out other gynecological issues. As women age, that becomes, dryness can become a major issue that can be treated. Another symptom that's often passed over is temperature dysregulation. Some people say that 1 minute they're freezing, the next minute they're excessively sweaty, and it can be really debilitating for people. Excessive sweating is generally a bit more common than coldness, and it can actually precede diagnosis by about 2 to 10 years. And again, this is related to autonomic dysfunction, and it can actually be a symptom of wearing off. So as people's Parkinson's medications are not working anymore, you can develop this excessive sweating as a way of your body telling you that you're getting low on dopamine, or it may be completely unrelated to medication. Unfortunately, minimal treatments are available. So there's very little available to help with both coldness or sweatiness. I often tell people to wear layers of clothing, do as much as you can that way to be able to take off or put on things as you feel cold or hot. For medications, like I mentioned, it can be a wearing off symptom, so smoothing out your symptom control by changing your dosing frequency or your schedule or adding new medications that prolong the effect of levodopa may be helpful. And then there's this new evidence that deep brain stimulation may be useful and actually help treat excessive sweating. Certainly no one would get DBS for this reason. If everyone here, I'm not sure if everyone is aware of what DBS is or deep brain stimulation, but this is a treatment where electrodes or wires are put in a part of the brain involved with Parkinson's, and they're connected under the skin by a wire to a pack or like a pacemaker in the chest. And you can change the voltage and the current of those wires in the brain to help with Parkinson's symptoms. So people who are getting DBS for other issues related to Parkinson's may notice a benefit on their sweating as well. Another issue is drooling. People with Parkinson's do not produce more saliva than other people, but they swallow less frequently. And this is actually a motor symptom because just like your arms and legs can slow down, your swallowing can slow down, and the muscles can just be slower. I mentioned anyways because we often consider it a non-motor symptom. It can be really disabling for some people. It's more common as the disease progresses, 24% in early Parkinson's, 53% in later, and severe drooling affects 15%. I have a lot of people who have a little bit, they get a little bit of drool at night or just have to dab their mouth occasionally, but I do have some patients who it's a huge social issue. They don't want to go out in public because they're constantly dripping, and it's quite embarrassing for them. There are some treatments available. The drooling can be treated by blocking acetylcholine, and sorry, I apologize for that. Can be treated by increasing acetylcholine, my apologies, and glycopyrrolate, atropine, and Atrovent spray, all back to that, all block acetylcholine and can help with drooling. All of these medications, though, can affect confusion, and so if someone already has some cognitive impairment, I completely stay away from these medications because they can worsen cognitive impairment. I do use botulinum toxin injections at times. Botox or Xeomin, there are two brands actually, they can be injected into the salivary gland itself and they reduce the amount of saliva that's produced. And you see this little picture here of the glands. We actually have 3 glands on each side that produce saliva. And generally the only gland that's injected is the parotid gland here. So people often worry that after they have this, the ejection cells have experienced a dry mouth, but you do have 2 other sets of glands that are producing some saliva. So dry mouth is not usually a major issue. I do have patients though that have dry mouth and drooling, and you can have them both at the same time, and that can be very difficult to treat. Botulinum toxin injections are quite effective. There's quite a number of research studies indicating their efficacy or effectiveness, and I find in practice most people do notice an improvement to their drooling to some extent with the injections. Problem is that this is not covered again by the Ontario Drug Benefit Program. This problem and that toe sticking up, that toe that's kind of extended in dystonia that I mentioned with pain, both of these are not considered indications for botulinum toxin by the government. And so people who want these injections for either drooling or for that toe dystonia pay out of pocket for the most part. I can apply to the government and put in an application to try to get it covered. And I've had a little bit of success with the toe, getting Botox for the toe covered in that way, but no success with drooling. So people do have to pay out of pocket. And Botox is quite expensive as a medication. 50 units, which is generally what people need most of the time. Sometimes they need a bit more, but usually about 50 or less. 50 units is about $200. And so they have to get it redone about every 3 months. And so it is an expensive treatment, unfortunately, but it can be helpful if it's a major issue and we cannot use the other medications because of thinking and memory troubles. External beam radiation therapy, so this is radiation to the salivary glands, can actually shrink them, and so they produce less saliva. I've actually never seen this done. I read about it as a suggestion. Maybe it's done more in the United States. I've never seen this done in my training. I spent 2 years in Toronto, and no, it was never brought up. But it's something when I was reading about it, this is very interesting, and it's certainly something that I will pursue now that I've read about it. If I have patients who are having a lot of drooling, to see if I could try to arrange this. I'm really not sure if it's possible here, but it is an effective treatment for drooling. So in conclusion, non-motor symptoms are extremely frequent and important components of Parkinson's disease. They can appear at all stages of Parkinson's, although they're more common as the disease progresses. They actually may help with the diagnosis. If people have that REM, sleep behavior disorder, or smelling issues, those are points that lead me to be more confident about a diagnosis of Parkinson's as compared to another condition. And there's treatment for many of them, and so it's important that if you're experiencing them that you discuss them with your neurologist or your family doctor. In the future, there's a lot of work to do, of course. It's very important that new therapies are identified and developed to better treat some of the non-motor symptoms. A lot of time, the treatments aren't as effective as we'd like. There's some thought that there's a lot of work being done on stem cells. There's being work done on turning stem cells into dopamine-producing cells in the brain, and so far that unfortunately hasn't completely panned out, but they're still doing a lot of research. Other people are researching turning stem cells into other neurochemicals in the brain that are affected in Parkinson's disease. So maybe stem cells will be a way to treat non-motor symptoms in the future as well. And then, of course, we also need new therapies that actually stop or prevent the progression and development at all, not just treat it, but stop it from developing. And this really is the way that research is going now. We are looking for disease-modifying treatments for the motor symptoms and for the non-motor symptoms of Parkinson's disease. So thank you very much. I hope this was informative. So the first question, my wife has Parkinson's since being diagnosed by Dr. Paulson in Hamilton in 2001. Does she need a movement disorder specialist? I'm not sure. So there is a doctor named Dr. Paul Seth in Hamilton who is a movement disorder specialist as well. I do full-time movement disorders. Dr. Paul Seth, who's nearing the end of his practice, does both movement disorders and MS. So he sees only part-time movement disorders patients. He's excellent. So I'm not sure if Dr. Paulson, I think, is a family doctor, but I'm not sure. But there's a Paul Seth who is a movement disorder specialist. And if you're seeing Dr. Paul Seth, great, he's excellent. And he's another movement disorder specialist. Regarding just in general, oftentimes early in after the diagnosis of Parkinson's, general neurologists are very competent to manage symptoms. I act as a resource for a lot of them who just want some advice on people who are having issues with motor fluctuations or non-motor symptoms, and people often get sent to me just kind of for a tune-up, and then I send them back to their general neurologist for further management, because general neurologists often do have a lot of knowledge about Parkinson's. But I do say that sometimes I find that they do not address all of the issues. They they see a lot of different things, and they just don't have as much knowledge, or they don't keep up with the literature with Parkinson's as much. So there is certainly a benefit in seeing a movement disorder specialist who would just be more in tune with all of the different Parkinson's symptoms. Please comment on Lewy bodies in the gut and in the brain. So it's been really interesting. We do know that there's Lewy bodies in the gut, like I was mentioning, and there's some thought, like I mentioned, how constipation can happen years and years before diagnosis of Parkinson's. It may be that Parkinson's, that the Lewy bodies are actually present there first, and that they start in the gut and then they move to the brain after time. This is in debate right now where the Lewy bodies actually start, and so they may be occurring in the gut at the same time or before. There was a big study that did biopsies. When people were having their colonoscopy, they biopsied the gut tissue, and that's where they found that there were these Lewy bodies present. And they are working at this further to determine whether this will be a way of diagnosing Parkinson's. So maybe even before people have symptoms, if they're having the regular colonoscopy, you can take a bit of gut tissue and actually find Lewy bodies. And if that's the case and they don't have Parkinson's motor symptoms yet, there'll be maybe a new medication that can actually stop the disease before it starts. So I think something like that, if it's ever used as a diagnostic technique, we need to have medications that then we can give people to stop Parkinson's from happening. But that is something that researchers are looking at, if we can diagnose Parkinson's because of these Lewy bodies in the gut. And they are certainly connected. Enemas in the treatment of constipation. Enemas sometimes are necessary, unfortunately. I mean, that's not a great long-term way of managing constipation, but sometimes it's necessary, and some people do require enemas if they can't get a hold of their constipation with other measures. So unfortunately, we do have to sometimes use enemas, but there are a lot of different over-the-counter medications, and sometimes just about finding the right combination to get adequate control of constipation. And then is dementia inevitable in Parkinson's disease? Dementia is unfortunately very common as Parkinson's progresses. A lot of people with Parkinson's, almost most truly, unfortunately, go on to develop dementia right now. Hope is that this will change, and in 5 to 10 years we'll have better treatments, again, treatments that slow or stop the progression. And so I should say that, so there's, this is kind of a big study. There's a big study called the Nun study, okay? And that nuns, there was a lot of them that basically gave themselves to science, and they were followed very carefully while they were alive, and then also the autopsies were done on them when they died. And these nuns, they did lots of different memory tests on them, and during their life, some of them were diagnosed with Alzheimer's, and some of them weren't diagnosed with Alzheimer's. And so then they when they finally died, for whatever reason, their brains were looked at under a microscope, and some of the people who had Alzheimer's had all the changes in the brain indicative of Alzheimer's. Some people didn't actually have Alzheimer's changes. They had strokes only or other things like that. So they had been diagnosed with Alzheimer's, but they had never actually had Alzheimer's. It was strokes that had caused their dementia. And then some people, they had the Alzheimer's changes in the brain, but they actually didn't clinically have Alzheimer's. They were never diagnosed with Alzheimer's. So that tells us that just because your brain is having these changes over time pathologically, you may never actually show the signs of the condition. So with respect to dementia in general, all those different suggestions I mentioned about learning new skills and keeping your brain healthy, those things can actually prevent you, or at least reduce the likelihood that you show the symptoms of dementia, that we can't change right now that these changes will be happening in the brain, that they can lead to memory and thinking problems, but there are things that you can do in your life that make it less likely for you to be impaired by those changes. I hope that in the future we can stop this from happening, but dementia is a common thing, but can be minimized in some ways. Does domperidone help with dizziness? So if it's just dizziness, no matter what the change, what position you're in, whether it's lying or sitting or standing, then domperidone doesn't treat that. What domperidone treats is dizziness related to that orthostatic hypotension, if it's related to levodopa. So if you're taking levodopa, and after taking that, that's when you develop the blood pressure changes when you go from sitting to standing or lying to standing. And then domperidone can block that problem. It's a dopamine blocker. So it blocks the levodopa from causing the blood pressure to fluctuate like that. If you just have plain dizziness that's not postural, doesn't change with position, domperidone doesn't help. Dizziness is such a general term. Sometimes people mean vertigo, like the world spinning. Some people mean lightheadedness, but you'd have to look for other ways to treat that if it's just plain dizziness that doesn't change. I'm allergic to levodopa. I developed a skin rash and had to stop taking it. Is this common? What can I do? That is very uncommon. It's extremely uncommon to be allergic to levodopa. If I had a patient who was allergic to levodopa, I'd probably send them to an allergist and immunologist just to kind of be further assessed. Levodopa is connected, of course, to carbidopa, with levodopa carbidopa, or levodopa benserazide, depending on if you're taking Sinemet or Prolopa. And maybe it's not the levodopa, maybe it's the carbidopa or benserazide agent. So one option would be to try the other brand. If you're just levodopa carbidopa, try levodopa benserazide to see if that causes the rash too. And then I tried dopamine agonists in someone who was having troubles taking levodopa, one of the pramipexole or ropinirole, or the vertigotine patch. What is your opinion of Azilect? It is so expensive. Is it worth it? This is somewhat of a debate even between movement disorder specialists. There was a big study called the Adagio trial that was looking at whether or not Azilect, also called rasagiline, slows down the progression of Parkinson's disease. Some people were on no medication, some people were on 1 milligram, and some people were on 2 milligrams of rasagiline. And the study found that the people who started, they started some people on 1 milligram or 2 milligrams at time 0, and then they started other people on it at 6 months, and then they followed them kind of maybe to a year. And so some people had been on it for a year, some people had been on it for 6 months, and they found that the people who had been on the 1 milligram dose for the whole year seemed to have less symptoms than people who'd been on it only 6 months, suggesting that maybe it has a neuroprotective or disease-modifying role. Interestingly, though, the 2 milligram dose did not show that same benefit. And so scientists think that doesn't really go, what we know about how medication works, there's no clear reason why a 2 milligram dose wouldn't even get a better effect, or at least the same effect as the 1 milligram dose. And so, and this was just one study, and so this is really not actual, 100% certain information. And so I know some movement disorder specialists, if you have even mild symptoms, they'll put you on rasagiline just because maybe it has this neuroprotective role, whereas other people don't do that because it's expensive and it really has not been proven to do that yet. So it really, in my training and my personal opinion, it's not common that I place people on rasagiline for that reason. Sometimes I mention this whole debate to them and let them then make the decision for themselves. But it is very expensive, and from a symptom perspective, it isn't great for symptoms. It provides a modest benefit for symptoms. So my opinion is that I generally do not use it for a neuroprotective reason at this time. It's very expensive. It's covered by the government if you have a lot of wearing off. So if you have, if you're off because you have all these fluctuations during the day, if you're off for more than 25% of the day, your doctor could apply to the government to have it covered if you're over 65. For the most part, at this point, I don't think it's worth it. And there have been no new studies that have gone on to prove that it's neuroprotective. They are doing more studies, but nothing so far has shown that. So it's a tricky topic, honestly. Diagnosed 1 year ago, prescribed levodopa and ropinirole, but cannot keep them down even with domperidone, because domperidone is also used for nausea and Parkinson's related to the medication. Are there other medications I should ask my doctor about? Yes, we have tried very low doses. So that was good that they put that, actually. So certainly levodopa and ropinirole can both cause nausea. Levodopa is a bigger culprit. If you were on both and notice nausea or can't take them, I would probably try just ropinirole and try to max out that medication because it's less likely to cause nausea. And then if you still had nausea even on the ropinirole, what I'd probably do is use levodopa, carbidopa, and then apply to the government for more coverage for extra carbidopa. Carbidopa can help block the nausea as well. And carbidopa always comes as part of levodopa, and it's really difficult to get it on its own. You have to apply to the government. It has to be sent to a hospital pharmacy and then be dispensed from there. But they do approve it at times. You have to give them really good reason, the government, but they can. So you can get extra carbidopa, which can help with nausea, if you have to take levodopa and you have nausea with both dopamine agonists and with levodopa. Hope that clarifies that. Does Parkinson's disease increase recovery time to surgeries? It can. People with Parkinson's often can't do the rehabilitation techniques as rigorously because they're stiff or slow as people without Parkinson's. So sometimes the people do take longer to recover because they just can't be as aggressive with their recovery therapy. I think that's it. That's it, yeah. Oh, no, sorry, my apologies. 2 more. How can diarrhea be controlled after taking Prolopa? Diarrhea is pretty uncommon. Usually the medications cause constipation. If anything is going to cause diarrhea, entacapone or Comdan is probably the big culprit of the Parkinson's medication, and sometimes we have to just avoid using that medication because diarrhea is so bad. The first thing I do is make sure it's related to the Prolopa because because there are a lot of other things that can cause it, and because it's a bit unusual to get diarrhea from this medication. If it's from the Prolopa, I'd probably try Sinemet, the levodopa-carbidopa, rather than the levodopa-benserazide of Prolopa, just to see if another Parkinson's medication can work, or even a dopamine agonist again, if that's a big issue. But I would, if someone's having bad diarrhea like that, I think I would have them communicate with their family doctor or send them to a gastroenterologist to make sure nothing else is going on, because it's such an unusual symptom in Parkinson's disease. And actually, that's the last one, I think. Okay.